On the other hand, when you look at this cohort, you're talking about cardiovascular patients that are older men and are hypogonadal, which means they have a condition that has a number of effects that are very, very relevant to understanding testosterone's relationship to musculoskeletal health. For example, hypogonadism in men can be associated with decreased motivation and socialization, increased fatigue and apathy, depressed mood, negative outlook, loss of muscle mass, strength, and performance, decreased bone mass, and not counterintuitively, decreased physical activity and exercise, and hence increased risk of sarcopenia and frailty, and I would suggest hence increased risk of musculoskeletal injury. Thirdly, there are effects of testosterone treatment that have significant implications in regard to the relationship of testosterone treatment to risk of fracture and musculoskeletal injury generally. Um, for example, current studies indicate that higher levels of testosterone and testosterone treatment itself are associated with a decrease in things like fatigue and apathy, improvement in mood, sociability, confidence, uh, improvement in joint stiffness and pain, improvement in motivation, including the motivation to exercise, improvement in mass and strength of both muscle and bone, and both of which are associated with a decrease in fracture risk. Studies have also shown an increase in impulsivity and, interestingly, an increase in risk taking.
So, are these effects consistent with your own research observations?
Yes, in our long term research, we certainly noted all the effects just mentioned as far as the effects of hypogonadism on men. In fact, many of our observations preceded their documentation in the literature. Same thing with testosterone treatment as well. But beyond that, very early on, we observed that these effects increased the level and intensity of exercise, and that increase in exercise and risk of exercise and behavior was leading to increased musculoskeletal injury.